Thank you. I'd like to talk to you about some of the problems we see in homeless populations. I'm a general internist. I work at the U and run this third-year student medicine clerkship. Did my chief residency at Harborview, where almost my whole patient population struggled with obtaining shelter. You know, they go in and out of homelessness, and then I've been volunteering at the downtown clinic that our students help run, and some of the other service learning things we do, where we do take care of a large number of patients that are homeless. So I'm going to go through a few cases here and go through a lot of pictures and talk about a bunch of different common things, both you can see visually, but also some medical problems that are pretty common in patients that are homeless. Here's the first one. A 47-year-old with a history of alcohol abuse presents with skin lesions. These have been present for 3 months and are worse when he has increased sun exposure. Which of the following tests should be obtained? Here's what his hands look like. And the main issue here is, you can see scabs, but can you see on the left hand, he's got a blister on over the third MCP joint there. So that's a pretty typical thing we see with this kind of a lesion. So my question was, does this ring a bell with any underlying disease, and what test would be a good one to do? So I'm not going to make you guys all answer, because I think you're trying to eat, and that's not nice. This is a manifestation of hepatitis C, and hepatitis C is very common in our homeless populations. And this is something called porphyria cutanea tarda, which is worsened with sun exposure, and alcohol makes it a lot worse as well. So people have an underlying predisposition from the hepatitis C they have. The alcohol use is a second hit, and then they show up with this manifestation. So 60 to 80% of people who have this skin manifestation have underlying hepatitis C, and it's triggered even more with alcohol use, and both hep C and alcohol use are much more common in our homeless populations than if you compare to non-homeless populations. Pretty much anybody who's seen with this skin finding should be tested for hepatitis C. This is another skin manifestation of hepatitis C virus. This is a vasculitis of the lower extremities that can occur with it. And this is due to something called cryoglobulins. These are antigen-antibody complexes that occur that can precipitate out at colder temperatures. They tend to occur more in the lower extremities, not because the lower extremities are always lower temperatures, but the dependent position, the fact that there's increased hydrostatic pressure when people sit and drag, have their legs dangling down, seems to increase the likelihood of this. So half of all people with hep C have mixed cryoglobulinemia, which can lead to these findings. And about 2 to 5% of people with active hepatitis C develop cutaneous vasculitis, which is what this one is. Here's another skin manifestation we see with hep C, which is something it's called lichen planus. It's these purple, planar, polygonal, paritic papules, the 5 Ps. So these are very, very itchy. They're often on the ankles. You can see them on the wrists, but they don't tend to be too much on the other parts of the body. And again, another thing that is much more likely in people with hep C. So we have a population that's fairly prevalent in the United States with hepatitis C, and we know that half of them don't know they have hep C. And they may come in with these things. You folks all have probably heard of lichen planus, right? It's not uncommon in the mouth. And just keep in mind the hepatitis C connection with lichen planus, that there's a possibility that may be what the trigger is for lichen planus. As all aware, this is the white lacy abnormality that we see, can see in the mouth. It can involve the gums. Usually it's described as asymptomatic, but I've certainly seen plenty of people with mouth lesions that are symptomatic. So it's on the skin, it's very, very itchy. It is polygonal, very common to have buccal mucosal lesions as well. And some drugs can make this can cause something that looks just like lichen planus. But remembering the hepatitis C association, especially in our homeless populations. If you find one of these things, what's the increased chance they have underlying hepatitis C? The vasculitis is the highest at 14-fold increased risk. The porphyria 9-fold, and lichen planus only 2.3-fold increased risk. One thing about hepatitis C I wanted to make a quick comment about was hepatitis C is really changing now. How many have been keeping up with all the new stuff about how we can now cure it in 8 to 12 weeks with medications? So this is a huge change. Viral illness, we always said this is chronic. It's in maybe as much as 10 to 20% of people who get it might end up with end-stage liver disease and need transplants or die from that disease. And now we have regimens that in 12 weeks have 97 to 99% cure rates. So this is a huge issue. What's the big problem with hepatitis C treatment? Cost, yeah, $100,000 for 12 weeks of medication. So it's not that we don't have the science and the ability to treat people with this disease. Many of them don't have coverage for this, and there's a lot of haggling over who should get treated. With most diseases, we like to treat people early, and we don't like all the manifestations of a disease to occur if we can cure it early. We don't want to, if somebody gets pneumonia, we don't want them, coughing their lung out before we give them antibiotics. But with hepatitis C, since so many patients can end up not ever getting sick with it or not having any clinical condition that's going to really impact their life, if you treated everybody as soon as they were found to be positive and it was $100,000, the cost would be absolutely phenomenal. So this is another physical finding of hepatitis C. This is something called Terry's nails. It's seen with cirrhosis, especially due to hepatitis C. And what we're looking at is, if you look at your own fingernail, you'll see that it's pink. You don't have a real dark band right before the end of the nail, and if you do, you still have pink nail. You still have a darker colored nail. If you see in people who have hepatitis C and Terry's nails, their proximal nail is white. You see how white that proximal nail is? You look at your own fingernails, that's not the case. So this is another physical exam finding that suggests hepatitis C, again, much more common in individuals who are homeless. Now, one of the interesting other treatments, I talked about medication treatment for hepatitis C. The single best treatment is abstinence from alcohol. That if you look at the likelihood of somebody who getting cirrhosis, if somebody is a non-drinker, they have a relative risk of 1. If they drink heavy alcohol, they have a 15-fold increased risk of getting cirrhosis. So everybody knows that. Everybody knows that people that drink alcohol really heavily have a risk of getting liver disease. That's not new information. If you look at hepatitis C, if you have hepatitis C and you don't drink alcohol, your risk of getting cirrhosis is 9 times higher than somebody who's not hepatitis C infected who doesn't drink alcohol. But it doesn't mean that that's a certainty. If you have hepatitis C and you drink alcohol, in this case, they were looking at people that drank alcohol heavily, 147 times more likely to get cirrhosis. So one of the major interventions with hepatitis C, short of treatment with medications, is abstinence from alcohol because of this powerful interaction between hepatitis C infection and alcohol leading to end-stage liver disease. So we have multiple medications now that we can use, and every 3 months there's more data. The most recent from a month ago was this 97 to 99% cure rate. And so that's remarkably good. And the reason people with hep C die, some of them die from liver failure, and then the rest die from liver cancer. So probably 70-80% die from liver failure, but 1% of people with hepatitis C will die from liver cancer. And the idea behind treatment is if you can treat them early enough, you take away their liver cancer risk. Okay, a 55-year-old homeless man presents with discomfort in his leg and swelling. He has a history of alcoholism. He has problems with athlete's foot. His white count is 12,000. He's got a temperature of 37.5, blood pressure 130/70, a pulse of 88. Here's his leg. So he's got this red, warm, on exam it's warm, it's red, it seems to be spreading up his leg. You can see how swollen his ankle is and his leg. It's very swollen as well as part of this disease. So my question for you is, what do you recommend for him? Metronidazole, ciprofloxacin, trimethoprim sulfa, vancomycin, or cefazolin? How many people would want to use metronidazole? How about ciprofloxacin? How about trimethoprim sulfa? How about vancomycin? How about cefazolin? How about, why are you asking me an antibiotic question when it's not dealing with things going on in the mouth? So the right answer here is cefazolin, and this is somebody who has cellulitis. This is a very common skin infection that we see in the homeless population. Many of them have really bad shoes that have holes in them. The shoes are battered. Sometimes they're going part of the day without shoes on. They get a lot of cuts and scrapes. And then they get bacteria that get into the broken areas of the skin, and then they cause an infection in the soft tissue. And this is caused by strep. It's caused by group A strep, and the bottom line is it's very sensitive to the penicillin class drugs. It's very sensitive to the old-fashioned antibiotics. Very, very similar to how we still frequently use penicillins, amoxicillins for dental infections. The resistance pattern is very similar. It's still very treatable with our old-fashioned drugs. What's happened is that our entire country is deathly afraid of MRSA now, methicillin-resistant Staph aureus. So we're seeing more and more people choose to treat everybody for methicillin-resistant Staph aureus, even when they have a disease that isn't methicillin-resistant Staph aureus. This is a strep infection. It responds beautifully to cephalosporins and penicillins. And trimethoprim sulfa isn't a very, very good choice because it just isn't as good a strep drug. Here's just a study that was showing a remarkable response rate, 95% overall response rate when the penicillin beta-lactam class drugs were used, that these patients don't need vancomycin, that they don't need trimethoprim sulfa. Current practice guidelines for treatment of MRSA in outpatients with non-pussy cellulitis, no drainage, no abscess, go ahead and treat with a beta-lactam antibiotic and not worry about MRSA. Okay, a 25-year-old man presents with a rash. I'll show you in a minute. He has tried hydrocortisone without any improvement. This rash was worsened over the last 9 months, now affecting his scalp and his axilla. What do you recommend? And here's what his rash looks like. So he's got all this flaky stuff kind of going down to his lips. It's especially present in his nasolabial fold, sort of the creases of his nose. He's got it in his scalp, and he's also got it on his eyebrows. So what do we think's going on with this guy? Do we look to see if he has a weird rheumatologic disease by getting back films? Do we put him on antifungal treatment that's a very strong oral antifungal? Do we give him light therapy for psoriasis? Do we check to see if he's got leukemia by checking a CBC, or do we do an HIV test? And for this person, we'd want to see if he has underlying HIV. A much higher rate also in the homeless population of HIV. Reason for the increased HIV Hep C risks in homeless populations are many. Some may be that their risk factor may be injection drug use, and many of those folks will end up at some point transiently homeless. Sometimes individuals with major mental health problems and they've fallen through the cracks of our system may use drugs or multiple sexual exposures that may put them at risk for HIV disease, included sexual assaults, so that we see a higher risk of HIV in our homeless population. This is seborrheic dermatitis. 80% of people with HIV at some point will get this very common skin problem. This occurs in 10% of the population in general. It causes flaking in the hair and the eyebrows and in the nasolabial fold. It's caused by fungus. It's caused by Pittosporum ovale, which is a form of yeast that gets an overgrowth, and then the body will cause erythema, and it will also cause flaking in this area. Treatment is generally given with a topical antifungal like ketoconazole, or you can use a topical steroid cream like 1% hydrocortisone. Cleans this up and gets rid of the flaking and the redness. So we like to use steroid creams, ketoconazole cream. You can use shampoos as well if they have a lot in the hair, and then just clean their face with it. The other disease that causes seborrheic dermatitis very commonly is Parkinson's disease. We don't see a lot of people with Parkinson's disease in the homeless populations because most people with Parkinson's disease have, especially as it advances, the care needs are so great that these patients will, if they were homeless, they'll end up usually in a nursing home or somewhere where they can get more care. But interesting why people get seborrheic dermatitis with Parkinson's disease, it's the lack of facial expression. That the constant use of our facial expression seems to protect us from seborrheic dermatitis, the overgrowth of yeast. That as long as our facial muscles are working a lot, it decreases the likelihood that that will happen. 26-year-old homeless man presents with really itchy lesions on his arms and legs. They have been present for the last week and have not improved despite treatment with 1% hydrocortisone. On exam, he has multiple lesions on his legs and arms as well as several lesions on his scalp. So he's very itchy. They haven't gotten better. He's put a little steroid on him. That's what doctors do all the time. If they don't know what it is on the skin, they throw a steroid at it and see if it gets better. Well, he tried that and that didn't work. So this is what they look like. They're kind of punched out and look like little stabs. And he's got them on his scalp. He's got them on his arms, his legs. What therapy should we give him? What this is a patient with something that's called ecthyma. And ecthyma is a strep infection. Just like cellulitis, this one's a strep infection a little bit deeper. Cellulitis is in a level. Ecthyma goes into the skin, causes the crusting a little bit deeper, and it's a strep infection and needs to be treated with anti-streptococcal antibiotics. So dicloxacilin's the right answer here. How many people have heard of impetigo? Impetigo is something we see in kids. It's a strep infection that's very, very superficial part of the skin. Ecthyma goes deeper than that, but they're the same bacteria, but just look a little bit differently. Very, very common on the legs. And in the United States, the majority of patients with ecthyma are homeless. And again, it's because they get scratches, they get abrasions to their legs, and they can get a portal of entry for bacteria. Our skin does a really nice job of keeping bacteria out. That's why we have skin, so that bacteria can't get into our system. The only way bacteria can get into our system, if bacteria coming in with food we eat or internally, then it really has to go in through our GI tract to get into our body, and we have acid in our stomach. So there are really good defense mechanisms to keep bacteria out. But when people cut themselves and have a lot of breaks in the skin, then they have an increased risk of getting bacteria arriving that way. Here's just a picture of impetigo, just sort of the crusty stuff around the nose. Same organism, group A strep.
Can I ask a question?
Yeah, of course.
So if you're touching around the face and you touch an area and then you touch a different part of the face, you spread it that way, or?
Usually not, because usually it has to get under the outer layer of epidermis to really get going. So although impetigo people will be very worried about it spreading between children, it's not that easy to spread it within a person. It's just a source of strep that other people can pick up, but it's not super contagious. Yeah?
For antibiotic, is it PO or?
Yeah, we usually give it PO. You can give, if it's a small area of impetigo, you can put topical antibiotics on. Good topical strep antibiotics, things like mupirocin, which works well for that. Some people will use bacitracin and other things that might work like that. But once things get more than about the size of like a quarter, it gets dicier to put enough antibiotic on. So when people have 2 or 3 spots that are involved or half their face, we go with oral antibiotic.
We go for a week?
Yeah, a week. Perfect. Yeah, for any skin infection, we don't treat for more than a week because you're able to clear these infections fairly quickly. The longer you give antibiotics, the more likely people will get Clostridium difficile as a complication of it. Any other questions?
On any given evening when you go to do the dermatology clinic at Downtown Emergency Shelter, how many cases do you see of different derm things?
So we'll usually see 8 to 10 patients, and the number one diagnosis at our downtown shelter is fear of scabies. The patient thinks they have scabies, but they don't. They're very itchy, and they're just scratching away at themselves, and they get a lot of body lice there. That's very, very common, and that's the most common reason they itch. We do see some scabies there, but what we see next, one of the more common things, we'll talk about skin cancer. We see a lot of skin cancers there because these folks have been outside a lot. They get a lot of exposure to sunlight because during the day at the shelter, you have to leave by 6 or 7 a.m. and you can't come back till 6 p.m. So during the day, they have to be somewhere. And during the nice weather months, when we actually have sun in Seattle, people are outside, and so they get 12 hours of sun. And very few of these folks have the money, resources, or the availability of sunblock, so they're getting massive sun exposure. Other things that we commonly see, we see a lot of athlete's foot. That's one of the more common things we see. We see things that have to do with their feet getting all beat up by the fact that they have one pair of shoes and they've had it for 2 years. They have holes in the shoes are pretty disgusting, they smell bad, they haven't been able to be cleaned in any way, shape, or form, they haven't been able to be replaced. Some of them only have 1 or 2 pairs of socks as well, so we see a lot of fungal infections because they can't change their shoes or socks. So let's go and look at some skin cancer. This is really such a big problem in the homeless population because, as I say, they get so much sun exposure. So you're seeing a patient, one of your colleagues in the urgent care clinic for management of worsening diabetes, and talking with the patient, there's a small papule under the left eye, and here it is. Seen this so commonly. You can see the person's a little bit older. You can see all the wrinkles. That's effect of photo changes on the collagen in our lower, just under the skin, and that is what leads to wrinkles. But you see this little red bump, and it almost looks like the little tiny blood vessels on this. And very common in people that are above the age of 50, and each decade of life, this thing becomes more and more common. What should you tell the patient about the lesion? It's benign and requires no monitoring. It is related to sun exposure, and the patient should wear sunscreen. It is an atypical, non-pigmented mole and should be biopsied. It is a concerning lesion that could be cancer and should be biopsied. How many people like 1? A, just say, don't worry, we all have these. How about related sun exposure and they should wear sunscreen? How about it is a non-pigmented mole and should be biopsied? How about it is concerning that it could be a cancer and should be biopsied? So yeah, it's a basal cell carcinoma, so D is right. I think it needs a biopsy, and B is correct too, in the sense that it is related to sun exposure, and they should wear sunscreen to decrease the risk of this happening in the future. But for right now, we need to biopsy this and get this off. And so this is a basal cell carcinoma, which is a very, very common skin cancer in people in this country, and over the age of 50, very, very common. It's estimated maybe 1 in 3 Americans will get one of these. And I probably see 1 a week in clinic. My patients are just super common. I have a geriatric population in general in my own clinic. And then again, working at the downtown shelter, all these people have had sun exposure, so they're super high risk.
I have another question. Do you do biopsies there?
They don't do biopsies there, unfortunately. They don't have all the equipment, because the main thing is they have to have a number for a pathologist to read it, and they need to have all the equipment, and they need a hospital number to run it up. So with anybody with the basal cells there, we send them up to the Harborview Durham Clinic, and they get a biopsy up there. There's no problem getting them in. The problem is getting them to agree to go. Because, the homeless population is often fairly transient. Some of these people will stay for a week and then they're off to another city or something else. And so when we find a medical problem that's serious, like a skin cancer, it's really working with them the next day to get them up, to get that taken care of. The nurses at the shelter are very good about, we'll say this patient needs this. They will check on them the next morning, and they will try to facilitate it that day so the person can't leave before they get the care. But we know, even with that, about half of the people we try to refer never show up where we're referring them. Yeah.
Is part of it just because they don't want to know the final diagnosis? They're being blissfully ignorant about that?
I think denial is big. I think people are like, oh, this isn't hurting me. I mean, I didn't even notice it. It can't be that bad. Some of it is just logistics, and that for these folks, they don't have transportation. They might have to go back 2 or 3 times. They don't. It's so much harder to establish medical care when people don't have transportation. They don't have finances. All those things, because we think about it. I'll talk to the patients and they'll say, it's not one visit. I mean, I'm going to go up there and then they're going to want me to come back, and I'm not even going to be in this town next week, and I don't want to commit to that. But I think the only way that happens is denial, right? You have to believe it's not serious to let yourself not want to follow through. The other thing that I've seen in our older homeless population is that they tend to be very fatalistic. View of like, I'm 60 years old, I've made it this far, I'm homeless, I've already beat the odds. I'm already 5-10 years past the normal life expectancy for somebody who's been on the streets for 30 years. So they kind of are very fatalistic. So our view, which is everything early, promote health, try to keep everybody to have the longest possible life expectancy of high quality life. Many of the folks will say, you know, what happens, happens. So I think that fits into denial too. So that's a good point. I think denial is a big part of that. Other questions people have? So we'll show pictures in a minute. We can get this up and going. But the most common skin lesion, and some of you may have them already, they start to occur earlier in life, are actinic keratoses. Actinic keratoses are red and they feel like sandpaper. They're usually they're in sun-exposed part of the body. Usually we have them on our face. And the best way for people, when you're checking a person is just to feel. Do you feel a little patch of sandpaper? Look and see if it's a little bit red. These are precancers, but the good news is the majority of them go away. If the person's sun exposure goes away, which happens all the time in Seattle because we only get sun for a little while, if a person treats them with liquid nitrogen, they can go away. And only about 2 or 3% move on to become cancer. So we're constantly looking to see if people have these rough red spots from the sun and try to catch them before they become cancer. This is something I really wish we had. I wish we had liquid nitrogen in our homeless shelter where we go ahead and just freeze these lesions when we see them, because again, we have to send them up to Harborview to do that. Anyway, basal cells, the most common place is your nose, right in here, sort of this sun shelf right under your eye. Okay, that's the most common place. Other places I've seen a lot of them are the tips of the ears, because that can stick out in the sun. For many people they're covered with hair, which is good and that helps, but for most of us, we have where our ears are sticking out, and that just gets hit really, really bad with the sun. You see them on the arms, and interestingly, in the United States, we see more on the left arm. Why is that? Driving, right? So that arm might be wet outside, or it might be sunlight coming in through the direct sunlight side of the window. So you see it on the arm too, but really the face and the nose just sticks out there and grabs sun. Now, I'm going to show you some pictures of some other basal cells here. This is a really nasty version of basal cell, where the other one was sort of a red bump that you could say, okay, there's a red bump. This is more like a scar. This one looks like there's a little dimple there. It looks like a scar, and the problem with this one is it expands. It's usually 3 or 4 times bigger underneath the skin than you see. So for this patient, it's probably going all the way into the eye socket, and it's probably going all the way out to here. And if you remove that, you're probably going to have to remove about this much skin to get everything. And there isn't a lot of skin to do there, and that's very disfiguring. So one of the reasons we like to get basal cell carcinomas early is because very disfiguring on the face to have to do the type of surgery to remove all of the tumor. The good news about basal cells is in general they don't spread. They don't tend to metastasize. The bad news is they can kind of erode into things, and if you don't get them, they can kind of sort of erode off part of the face, or they can actually extend inward into the skull and do some other bad things. So this is a nasty form that is this more skin scar form, and is far worse than the other kind I showed you as far as finding it early. Here's one that just looks like some scabs. I mean, it's easy to look at that and go, oh, he just scratched himself. So whenever you are examining an older person and you see sort of red rough areas, you just ask them, have you noticed this? Do you know how long this has been there? And I don't really trust the stories people give back to me when they say, oh, it's always just there. I had a patient one time tell me, I found this huge red area that looked terrible on her shoulder. It looked like a bad basal cell that was about 10 centimeters in diameter on her shoulder. And I go, how long has this been there? She goes, oh, I got a shot 15 years ago, and it started right after that, and it was a reaction to the shot. I said, I don't think so. She goes, yeah, it was. She's a nurse, and she was very vehement. I go, please let me biopsy this thing. And she goes, okay, just to prove that I'm right. So I biopsied it. It was a superficial spreading basal cell, and it was very, very large. And so sometimes people will say, it's been there a day or two when it's really been there longer. So we usually do with these types of things, in this case where you see this red, this is a big actinic keratosis, what I told you about, that rough red spot. And then there are a couple little scabs here. What I do with these things is I just freeze the heck out of them. If you freeze them, the skin will fall off, new skin will form underneath it, and we can usually treat a mild early basal cell with liquid nitrogen as well, if it's in a non-cosmetically important area. If this recurs and it's behind their ear, that's not a big cosmetically important area. Then we'll just biopsy and remove it then. The other thing I want you to see on the ear, anybody see a little red spot on their ear? That's an example of one of these actinics showing up on the ear in an area that's gotten hit hard by sun. So the principal cause for these actinic keratosis is just cumulative sun exposure to UV light. So because it's UV light, you can get some benefit with your sunscreen, so that's an important thing to do. Always go out and wear sunscreen when you're going to go out for a while, even in Seattle. There are always sun-exposed areas. There's definitely a gradient risk based on your skin type. So people who have very fair skin, especially people who have fair skin and red hair, the risk is much higher for sunburn, for actinic keratoses. People with darker skin, darker hair tends to be a lot less risky in some populations. The treatment for actinic keratoses is liquid nitrogen. We just put it on there, we freeze it, and it flakes off. Now, some people don't like to be treated, and they say, you know, just give me time, doctor. Give me 3 months, and we'll do that. These things don't become cancer in 2 to 3 months. It takes several years. And there are people where these things will go away if they avoid the sun. So if they start using sunblock, they avoid direct sun, we may find in 3 months that their actinic keratosis has gone away. Now, I have some patients that have 40 or 50 of these on their body when I see them. They have them all over their face. Men who are bald on the top of their head. They've been out, you know, sunning themselves, so they got them on their back and their chest. And how can you freeze 50 spots? When they get too many spots, we use topical chemotherapy. We give them 5-fluorouracil. And that works really well. It causes them to slough their skin. Really, for the homeless population, 5-fluorouracil probably isn't going to be a good option because they're going to need to put it on daily for several weeks. And it's really a challenge for these folks to protect their medications during the day sometimes. So, you know, with that group, if possible, we'd want them to get liquid nitrogen, get sort of definitive therapy one day. All they have to do is go to the clinic once and then try to treat it. Here's heaped up squamous cell carcinoma. This is what becomes of an actinic keratosis that's untreated and expands. Squamous cell carcinomas are much more deadly than basal cell carcinomas. These can spread. They can spread to the lung, the brain, they can spread to the liver. These can be a real big problem, and so that's why we like to catch these spots early and freeze them and try to get rid of them. So the good news is we usually get warning. They usually don't occur suddenly. They usually take several years without treatment before this thing will evolve into a squamous cell carcinoma. Now, one last comment on the skin cancers. The older somebody gets, or if they have immunodeficiency like HIV disease or getting cancer chemotherapy, they're more likely to get skin cancers, especially squamous cell cancers, and those cancers are much more likely to spread because our immune system plays a huge role in prevention of cancer spread. So the thought is that most people, almost everybody, has cancer cells developing every day, but we have great immune systems that recognize these and destroy these so people don't get clinical cancer. As people get older, their immune systems wane, and as they get immunosuppressed, they don't have a good immune system anymore, so we often see cancer as a manifestation of immunodeficiency, either with HIV disease or people getting chemotherapy for rheumatologic diseases or other malignancies. Okay, this is another disease that's more common in homeless populations. 30-year-old man with C3 HIV disease with a CD4 count of 100 presents with fevers, weight loss, and a dry, non-productive cough. He has a history of pneumocystis a year ago, occurring in a CD4 count of 150. He has a history of injection drug use and is still using drugs. He's not been taking PCP prophylaxis. He's febrile, tachycardic, and his labs are all normal, except for a little bit of anemia. So this guy's been coughing. This guy's short of breath. He's got weight loss. He has a history of pneumocystis. He has a history of HIV disease, and he's still injecting drugs. He has this very odd x-ray, when we get an x-ray of him, which shows really remarkable hilar and paratracheal adenopathy, and the rest of his lung is clear. What this is actually an example of is tuberculosis. This is tuberculosis in a person with AIDS. People with bad immunosuppression, their tuberculosis is weird. It isn't typical. Do anybody know what the most common x-ray finding in tuberculosis is? Where is the lesion? Upper lobe? Yeah, so upper lobe infiltrates. Very, very common with, I have terrible hearing. Whatever you said was right. So upper lobe infiltrates are very, very common because they believe that they have to have a high oxygen tension for the tuberculous bacteria to grow. This is odd. This is not anywhere where there would be significant high oxygen tensions. These are actually lymph nodes that are loaded with tuberculosis. And people with AIDS don't get upper lobe infiltrates in general with their tuberculosis. They don't get lots of lung infiltrates. They get more adenopathy. And so with their weird immune system, they get a weird presentation. The other interesting thing is, you may have heard, tuberculosis causes cavities in the lung. They talk about cavitary tuberculosis. And when people have cavities, it's very easy to spread it. Cavities are made by your immune system. If you don't have an immune system, you can't make cavities. So if TB is going on in your lung, you'll just let it go on. You won't be trying to fight it and make these cavities. So we don't see cavitation in patients with tuberculosis and AIDS. Here is that upper lobe infiltrate with cavities in somebody who has TB, who has a normal immune system. Okay, so this is what we expect recurrent TB to look like, occurring in the upper part of the lungs and causing cavities. Cavities are incredibly infectious, and I bring this up as, for folks in the dental profession, there is nothing more infectious than when tuberculosis is cavitary or it gets on the larynx and, in the upper airway. These organisms are just sent out. And so one of the things that I know that whenever I go to any doctor now, and certainly my dentist, they give me a little health checklist, just sort of make sure that we pick up on the people that potentially could have active TB, because when they have active TB, they're very, very, very infectious when they have cavities in their lung, and especially in the upper airway. Sometimes they'll say they have sore throats, and they might stumble in, coming in saying that they're having mouth and throat pain, when what they really have is TB all the way from the lungs on up. So when we see people with advanced HIV disease, such as we see in the homeless population, not uncommonly, these folks tend to have a lot of lymph nodes involved, and they have a funny-looking X-ray with all the nodes in the X-ray without the typical upper lobe infiltrates like I just showed you. So this is somebody with an immune system. This is somebody without an immune system. This is what it looks like without an immune system. This is what it looks like with an immune system. Okay, now another thing that's super common in our homeless population is pneumonia. Pneumonia is really common, and our homeless population has a bunch of risk factors for pneumonia. Probably the biggest one is drug and alcohol use. Because when people drink heavily, they knock out their cough reflex to some degree, and they're more likely to aspirate. The most common way we get pneumonia is aspirating the bacteria into our lung, and then our immune system can't fight it off. That's the most common way people get pneumococcal pneumonia, the most common form of pneumonia. HIV increases that risk as well because they can't fight off the bacteria that gets into their lungs. So we see a lot more bacterial pneumonias in people with HIV. And in our homeless population, next to skin problems, I'd say probably upper respiratory problems, including pneumonia, are the most common. And very, very common in people who drink heavily. Also common in people who inject drugs, especially heroin. Because people who inject heroin, if they inject too much heroin, they knock out their cough reflex. So any aspiration into their lungs, the bacteria will sit there until the effect of the drug is gone, and that can let infection take hold. Okay, a 40-year-old homeless man with HIV presents for evaluation abnormalities seen in the oral cavity exam. What is the cause of this lesion? You guys are going to be all over this, I think. This one's pretty common thing we used to see when we were taking care of people with HIV years ago. We don't see it as much anymore now that we have people on antiretroviral therapy. So what do you think the cause is? HHV8, parvovirus, Candida malignancy, or Epstein-Barr virus? So this is oral hairy leukoplakia, and it's more commonly described in patients with HIV, although it's in the last 10 years it's been described in other immunosuppressed populations. They used to say this was pathognomonic of HIV disease, but it isn't. It can be seen with other immunosuppression, but it's really reactivation of EBV. Here's some flat lesions that we can see on the bottom of the tongue, which are a little less common than the corrugated lesions that you can see here. Generally, it's asymptomatic. The patients are not, they might be aware of it, but they're not complaining of it. It can be treated if the patient's really upset about it, or if it hurts. We can give them high doses of valacyclovir, famciclovir, acyclovir, and it will help it, but usually we don't treat it because it's usually asymptomatic. So we can't scrape it off because it's part of their tongue. It suggests HIV disease, and it's due to Epstein-Barr virus. This is what we used to see a ton with patients with HIV, which was unbelievable oral candidiasis. I mean thick, an inch or two thick. We don't see it as much anymore because, again, if they have good immune systems from the medicines we give them, they don't tend to get as much candidal infections. The forms that get missed in my clinic is the atrophic form on the top, where the tongue is very shiny and red, very sore, and the patient will say they can't taste very well. And that's a form of candidiasis, just like the pseudomembranous sort of white cottage cheese stuff we see. And we see the atrophic form fairly commonly in people that use inhaled steroids incorrectly, or asthmatics who just sort of stick the inhaler in their mouth and then just sort of spread the stuff all over their tongue. That makes for a great environment for yeast to grow. So there are a couple of different forms of candidiasis. Again, our homeless populations, this is a big issue when they get it because they can't eat. They don't like, they have some pain in the back of their throat as well. And we see more severe HIV disease in our homeless populations because of the lack of follow-up. The patient's not always going in regularly for follow-up. And if they don't follow up, they're not getting their HIV meds. Okay, this is a very, very common skin problem, and I see it a ton. This is one of the things I see about every other time I'm in the shelter, is somebody saying they got burning and terrible pain in a dermatomal distribution on their skin. What's this? Shingles, absolutely. And it's much more common in HIV, and we see a lot in our homeless populations because their nutrition isn't good and the stress they're under is huge. Both of those things increase the risk of showing up with shingles. The biggest risk factor is getting old. As we get older, all of us have a higher risk of shingles, but when we're younger, stress, poor nutrition may let this happen. This is reactivation of chickenpox virus, so anybody who's had chickenpox still has it in their body, and it's just sitting in a nerve ending waiting to break out when our nutrition levels go down, when we get stressed, or when we get an immunosuppressive disease, or we're put on immunosuppressants. So just to summarize, hepatitis C and HIV are more common in homeless populations, so being aware of some of the manifestations that we see in these populations can help us make diagnoses that might be missed. And then we see a lot of things that occur from exposure, be it the problems with the feet from poor shoes and not having socks, cellulitis infection because of breaking down on the skin, and then skin cancer from chronic sun exposure. I think that's the last thing I have here. If there's a minute or two, I'm happy to take the last couple of questions.
For those of you who've been working at UGM or other clinics, has anybody come across things that they might have a question about or seen? You're all doing good head and neck exams, right? Mucosal exams. So, actually, I think we haven't seen too many patients. I would get the sense that have HIV. Do you feel like HIV is frequently now in the shelter?
We still see quite a bit of HIV in the shelter. The total numbers in Seattle have declined some as far as new cases of HIV. The total numbers are staying very stable because people are living with it. I have an HIV clinic. I take care of HIV patients since 1989, and I have about 40 patients I take care of, and I had about one per month die up until 1995 when we got good therapy, and I've only had 4 deaths since 1995. So you see the prevalence of it out there is stable, but the new cases tend to be less, and we think that's because so many people are on therapy that it decreases transmission of HIV. If people have a negative viral load from being on therapy, they're less likely to transmit it to others. So that we think that's the reason for the decrease in new cases. As far as when I started out, all my patients, I would always teach my students, the number one place to check on these patients is in their oral cavity, because we would find everything. We'd find hairy leukoplakia, we would find candidiasis, we'd find aphthous ulcerations, which were common, we'd find oral Kaposi sarcoma. A lot of these patients have horrible gingivitis, and that's one of the last thing, I still see it in my well-controlled patients, is bad gingivitis. They much worse than age-matched population. But by and large, with all the medications, we see less new cases, and we see a lot less of the manifestations we used to see.
That's good to know, because the clinic that he's working in is a block away from UGM. That means it's the same patient population. So whatever he's talking about is what we're seeing with our patients. We may not be focusing on it immediately, but we do need to know if they have HIV or tuberculosis, right? We're right by their face. And also, if they have skin cancer, they're literally wearing each other's face, right? So.
And you'll see it on their lips, you know, it's hard to miss some of these facial, and you'll see a lot of squamous cell cancers on the lips too. So even just doing a very brief exam, you'll run into it, these folks who have had so much exposure.
And we're working towards, we have teeth and toes, German dent. We'll get there. We'll have the students doing the oral exams right next to the German exam. So
Good.
thank you very much.
Sure.